Hi again, everyone. My name is Yasser Al-Said. I'm from Winnipeg, Canada, and I will be talking today about hemo-dynamics assessment. And I will be talking mainly about the blood pressure, how to assess the blood pressure trends and the waveform in sick infants. So I have muted all of the computers joining us. If you have any question, just leave it to the end. Hopefully I will have at least 5 to 10 minutes at the end for questions. I have 3 main objectives for today. The first objective, discussion about physiology of blood pressure, and then analysis of blood pressure waveform, and then the pathophysiologic clinical approach of hypotension in infants with some case scenarios at the end. I will be relying mainly in this presentation on blood pressure trends and waveform, and then assuming that you don't have TN echo or NIRS available. So if you are able to rely on the blood pressure in pathophysiologic or physiologic way, that could be enough, and if you know how to deal with these numbers correctly. We have good for outcomes like antenatal steroids, early CPAP surfactants, breast milk, delayed cord clamping, but at the same time we know that we have some other confounders bad for outcomes, including infection, inflammation, oxygen that we are using as like saving life, but at the same time it might be bad for outcome, hypoxia, mechanical ventilation, cardiovascular instability, and the medication that we are using to treat hypotension, they are also bad for outcome. So I will be focusing today about cardiovascular instability and cardiovascular support, and how to use this medication based on the blood pressure trends. If we go through the literature, there is no any consensus on the clear definition for hypotension in preterm infants. And I have selected just one study published in Pediatrics, that's official journal of the American Academy of Pediatrics. They reviewed a large number of babies included in the National Research Registry, and they found that antihypertensive therapy administration was not associated with improved in-hospital outcomes for any of the 15 definitions of low blood pressure investigated. So they have 15 different definitions of low blood pressure. Alternative methods of deciding who to treat are needed to maximize patient benefits and minimize harm. So I have another conclusion from this study. For the 15 definitions of low blood pressure investigated, therapy was not prescribed in 13 to 49%. So some definitions only 3% treated, and another definition, because they have 15 definitions, about 50% of infants, they prescribe the medication. They did not prescribe the medication in spite of having low blood pressure as per definition. Paradoxically, therapy was administered to up to 40% of infants without low blood pressure. So what does that mean? It means that the blood pressure is not only the marker of low blood flow or compromised cardiovascular system. It could be just a surrogate marker. You may have low blood pressure with a stable baby, and you may have normal blood pressure and otherwise, like with lactic acidosis, unstable. So the hypotension is not a disease. To randomize between two arms, one arm to treat and another arm not to treat, or placebo, you should have a clear definition for what we are treating, and you should have a distinguished disease or pathophysiologic mechanism. Hypotension is just a surrogate marker of cardiovascular compromise. So it is a marker of compromised blood flow. Blood flow might be compromised with low, normal, or high blood pressure. You may have high blood pressure with compromised blood flow, or even normal with significant lactic acidosis. Hypotension might happen with any of the pathophysiologic mechanisms of compromised blood flow. So what are the pathophysiologic mechanisms of compromised blood flow? We have poor myocardial performance, which may have normal or even high blood pressure. You may have low peripheral vascular resistance. You may have low preload, either pulmonary venous return or systemic, or both of them, systemic and pulmonary venous return, they might be low. You may have high afterload, which is contraction against resistance, so the heart contracting against high resistance. You may have stealing of blood through PDA or AV malformation. So clinical presentation for all of these mechanisms could be hypotension, acidosis, oliguria, or could be even normal blood pressure, or with poor peripheral perfusion. So hypotension, just one marker among these different clinical presentations or markers or surrogate markers, but it does not reflect really what is the pathophysiologic mechanism. So we have clinical signs, which could be hypotension, oliguria, lactic acidosis, low bicarbonate, poor peripheral perfusion, or tachycardia. But we need to know the mechanism. To target your management, you need to know what's the mechanism of compromised blood flow. So we have a high afterload, and you need to treat that by vasodilator. San Boniface, please, can you mute your microphone?
You're mute here. You might have to turn it on to tell them to turn it off.
I think that's from San Boniface. So you have to target your management according to the mechanism. If you have high afterload, then you need to select a vasodilator. If you have low preload, then you have to give more fluids or the isotropic medication, which is improving the diastolic performance, so allowing more or better filling of the ventricle, the same like mechanism of Merinon. Or you have PDA, left to right shunt, then you have to treat it. You have to give anti-steroid, anti-prostaglandin. Poor myocardial performance, you have to target your management to inotropic support. By having the clinical signs, you cannot get any clear idea about these mechanisms. If you have low systemic vascular resistance, then you have to target your management by giving vasoconstrictor. If you have indication or parameter that reflecting suprarenal dysfunction, either low random cortisol level or like suprarenal stimulation test, then you may need to give the dexamethasone or steroids to improve that. So we'll be talking today about hypotension. We'll be focusing more about hypotension. So basics of hemo-dynamics. We have few definitions that we need to understand. First, pressure. Pressure is a gradient required to move blood between the high pressure to lower pressure. So to move the blood from the heart to cardiovascular system, you need a pressure gradient. So the pressure gradient will be higher in systole and lower in diastole. And the pressure will be created by having a preload or stroke volume to create the difference between systole and the diastole. Then you have a volume. The amount of blood moved by this pressure gradient is a volume, which is cardiac output or stroke volume. Then you need a time difference to get back into the resting stage. So systole to push the blood in front, and resting stage diastole to get back into the resting stage and give a chance for new filling and push again another volume of blood, which is a new stroke volume. Then you have the flow. So flow, moving blood against the time, it is a flow. So rate of moving blood, which is a cardiac output. Stroke volume is different. Cardiac output is stroke volume multiplied by the heart rate, which is moving against time, which is we are using minute for a cardiac output. So how much blood moved in 1 minute from the heart to the peripheral circulation. Compliance is a tendency of easy going back to the resting stage. So the heart should be resting back to the diastole, and it is a compliance of the myocardial muscles. It is a diastolic function of the heart. And then you have the resistance. So you should have some resistance to allow moving of the blood and propagation across the cardiovascular system and going back to the heart. Too much resistance is bad, and very low resistance also bad. And then we have the afterload. Afterload is workload that should be performed to overcome resistance. So afterload is different from resistance. The workload that should be performed by myocardial muscle to overcome the resistance. So I have a cartoon which is explaining this in more details. So we have this circle here that's reflecting the venous return. Venous return is coming through the systemic venous return channels, which is superior vena cava and inferior vena cava, to the right atrium. And you can see here that the venous return is almost, or the prelude is almost equivalent to stroke volume. So what the heart is getting is equivalent to what the heart is pumping out. It's around 2 ml per kg. That's a really small volume compared to the entire volume exist in the circulation. So see the difference. That's really small volume, and to be ejected from the right atrium to the right ventricle, you need the pressure to be increased. So the pressure to be decreased first in the right ventricle, then they have the tricuspid valve open, and the blood will be moved to the right ventricle, and then the right ventricle start to contract. So the pressure will increase, then the tricuspid valve will be closed again, with more pressure increasing, and this pressure should be exceeding the pressure in the pulmonary artery. Then the pulmonary valve will be open, and the blood will be ejected out, which is a stroke volume, back to the left atrium through pulmonary vascular resistance. So the resistance here should be lower than the pressure in the right ventricle, which is afterload. If the resistance is very high and the right ventricle cannot contract against this resistance, we call that high afterload. Then the right ventricle will fail at the end. Then we have the blood in the left atrium, and there is no valve between the venous return and the left atrium. Once the pressure decreases in the left ventricle and decreases down to 0. So the pressure should be 0 in the left ventricle during at the beginning of the diastole to allow the blood to move from the left atrium to the left ventricle. The left atrial pressure is just between 3 to 5, very low pressure. Left ventricle during diastole should be 0 to allow the blood to move in the left ventricle, and then the pressure will increase again. Mitral valve will be closed, and then aortic valve will be open with the pressure increasing more, and the left ventricle pressure should be exceeding the aortic pressure for the stroke volume to be pushed, and should be exceeding the systemic vascular resistance. So there's afterload. So the left ventricle is ejecting the blood against systemic vascular resistance to push the blood across the circulation back to the right atrium again. And we have some numbers to remember across this mode of circulation. So what's the amount of blood exists in the circulation per kg? So in the arterial side we have 15 cc per kg in the entire arterial circulation for preterm infants, with assuming that the preterm infants blood volume is around close to 100 ml per kg. So we have 15%, which is almost 15 cc per kg in the arterial compartment. You have only 5 cc in the entire capillary. So see how tiny the capillary. So the entire body capillaries containing only 5 cc per kg of blood, and we have 80 cc of blood exist in the venous compartment, which is the capacitance and the reservoir of the blood in our body and the baby's body. The stroke volume, which is amount of blood creating the systolic blood pressure for each beat, is around 2 cc per kg. And if you multiply that by heart rate, you will get how much ejected per minute as cardiac output. In the pulmonary circulation, we have 10 cc exist in the pulmonary circulation in both lungs per kg. Even before the ejection of blood, before stroke volume, at the end of diastole, you have at least 10 cc. And also the stroke volume of the right ventricle is the same, like left ventricle is 2 cc per kg. So these numbers are very important to remember, and we have functional residual capacity of around 25 cc per kg at the end of expiration still exists in the lung. If you have significant increase in the functional residual capacity, then you may have increased pulmonary vascular resistance, and which may impact negative way the stroke volume from the right ventricle. Then this slide is very important to understand what's meant by systolic and diastolic pressures. So what does systolic pressure reflect? Systolic blood pressure is the pressure created by ventricle or ventricular contractile function to exceed vascular resistance. So is exactly reflecting afterload, and it is needed to push stroke volume through cardiovascular system. So it is reflecting both the stroke volume, and it's reflecting at the same time the pressure created or the workload created by the ventricle to overcome resistance and to push the stroke volume forward. So what does diastolic pressure means. So the diastolic blood pressure is a resistance by contractile property of the arterioles. So it is more reflecting the peripheral vascular resistance to maintain higher pressure gradient on the arterial side. So the pressure should be maintained during diastole after ejection of blood, and should be maintained to keep moving blood back to the venous circulation, and to maintain higher gradient in the intravascular volume, which is needed to maintain movement of the nutrient and oxygen back to the tissues. Mean arterial pressure. So what's the mean arterial pressure? It is just equation to make your life easy. It's reflecting systolic and diastolic, but it is more reflective of diastolic more than systolic. It's 2/3 of diastolic and 1/3 of systolic. It is one of the equations. There's other equations like twice diastole plus systole divided by 3. It is the way that like the monitor measure the blood pressure if you measure it indirectly. But direct blood pressure is different. It is a mean area below the curve if the machine is measuring direct blood pressure. So if the machine measuring in phase of blood pressure, it is different way to calculate the mean, different from the Dynamap or the indirect way of blood pressure measurement. So we'll take one by one, like pathophysiologic mechanism, and how to assess that by blood pressure numbers. Low preload, by definition, it's a preload. Preload is a diastolic filling of the ventricle until reaching the physiologic end diastolic volume. Is expected in. If we have or expecting low left heart preload, so the blood coming back to the left atrium is low from the pulmonary circulation, it could be because of pulmonary hypertension. So high pulmonary vascular resistance limiting the venous return back to the left atrium. It will affect systole more than diastole. And we have to expect also narrow pulse pressure. The difference between systole and the diastole is very important to evaluate. If we have the diastolic blood pressure decreasing and diastolic blood pressure is not really affected too much, then the pulse pressure will be narrow. That's very important to rely on. We know that why pulse pressure is important, one of the important parameters for PDA, but narrow pulse pressure is also important if you have low systolic pressure with maintained diastolic pressure. And I will give you examples from the like a snapshot from monitors for the same example. If you have low right heart preload, so the venous return coming through systemic circulation is low. It could be because of third space, loss of volume, like dehydration of hemorrhage, and it should be really significant loss of blood or volume to have low systolic blood pressure, because the body may compensate by increasing resistance and can maintain the blood pressure for some extent. But if you have very significant dehydration or low hemorrhage, you may have really low blood pressure. If you have low both right and left heart preloads, you may have that in external compression, like mean airway pressure, or tension pneumothorax, or cardiac tamponade if you have pericardial effusion, and it will be limiting both left side and right side venous return. So it will affect both actually systolic and diastolic blood pressure. High afterload, by definition, it is a contractile work load that ventricle should perform to overcome the resistance. Expected in failure of adaptation, like postnatal transition of preterm infant, very preterm, develop hypotension during the first or second day of life. It might be because he cannot tolerate the sudden increase in resistance, and his heart is not ready enough to contract against high resistance. To failure of adaptation of shift from fetal circulation to postnatal circulation. So early in this situation, you may have high both systolic and diastolic pressure. You may have high blood pressure at the beginning, but later on you may have decreased the systole with maintained diastole and narrow pulse pressure, and I will give you also an example of that. Poor myocardial performance, that's different from high afterload. So it is impaired ventricular contractility against low resistance or even normal resistance. High afterload, it is contraction against high resistance. Poor myocardial performance, you may have the heart not contracting well, but against normal resistance or even low resistance. I have two examples, common examples for that. Advanced shock. If infant is very severe shock, which is the early stage of shock will be loss of vascular resistance with maintained contractility, but at the end you may have low systole and diastole and collapse of circulation. Or cardiomyopathy, you may have cardiomyopathy and prolonged arrhythmia. In this situation, you may have low systolic with normal diastolic pressure because the resistance should be normal, and also narrow pulse pressure because diastole will be maintained, systole will be decreased. You will have narrow pulse pressure in this situation. What about low systemic vascular resistance? That's one of the most common reasons of hypotension in our population. It is peripheral loss of arteriolar muscle tone with generalized systemic vasodilatation. Expected in systemic inflammatory response syndrome like septic shock or NEC. You have low diastolic pressure. In this situation, you have low or normal systolic blood pressure, low afterload, and normal pulse pressure. So you have the diastole low, and the systole will be decreased at the same time because the heart does not require high pressure to eject the blood against low resistance. But very important, in this situation you have normal pulse pressure, so the diastole will decrease and systole will be decreased to some extent, but the pulse pressure will be maintained. And also I will give you a clear example for that. If you have left-right shunt, you have stealing of blood from systemic circulation to pulmonary. You may expect that in PDA or AV malformation. You have low diastolic blood pressure with high systolic blood pressure, or at least normal. In this situation, you have low diastolic pressure, but to differentiate between low diastolic blood pressure in PDA from septic shock, in this case you have wide pulse pressure. In the other case scenario, you have narrow pulse pressure. You have decreased diastole, but at the same time decreased systole with maintained pulse pressure. Now we need to know how to assess the arterial waveform. So the arterial waveform that you have it on the screen every day if you have a baby with continuous monitoring or invasive monitoring of arterial blood pressure. So that's actually the structure of the waveform. So we have upstroke, which is upstroke systole, and they have the peak of systole, which will be the systolic blood pressure reflecting on the monitor, and then they have systolic decline, and this notch here is reflecting closure of the aortic valve, which is dichrotic notch. Dichrotic, it is a Latin term, means like double notch. And then you have diastolic runoff. So beginning of diastole begins here after closure of the aortic valve, and then you have end diastolic pressure, which is a number reflected on the monitor. So you have beginning of the cycle, and there's the end of systole, beginning of diastole, and then the end of diastole. And you can recognize the diastolic time is almost double the systolic time. So that's actually a snapshot of the screen. That's normal waveform. So you have upstream of systole and downstream of diastole, and I have normal blood pressure. Now I will show you some abnormal waveforms to know how to differentiate between normal and abnormal. So first one, if you have strong and weak alternating, that's called arterial pulsus alternans, which is consistent with poor myocardial contractility. So the heart cannot maintain good contractility in all of the cardiac beats. So you have alternating weak and strong. So the peak systole, the diastole will be almost the same for all, but systole will be up and down. And you may have that also in myocardial tamponade due to pericardial effusion. What's the case in HSPD, hemodynamically significant PDA, or hyperdynamic heart? So you have the top part of the wave, it was made the systolic dip or double hump or double peak. Have you seen that before? Okay, I will show you the screen from the baby in the unit today. So you have the systole and the diastole actually between both. It's wide. That's wide pulse pressure. That's another sign of PDA. And we have hyperdynamic cardiomyopathy or low ventricular filling. In this case, with the hypertrophic cardiomyopathy, which is common in IDM babies, you have two peaks, but the first one is a spike and the second one is more smooth or dome. That's hypertrophic cardiomyopathy, and it's also common in low left ventricular filling. It's the same like the same scenario. If you have hypertrophy cardiomyopathy, you have underfilling of the myocardium because of the significant hypertrophy of the myocardium. And you have high afterload with low cardiac output. Have you seen that before? You have one systolic peak and the diastolic peak is actually high or prominent. That's common in low cardiac output and systemic vascular resistance. Have you seen that before? I will show you one of the screenshot from one of our papers. Okay, so the 38 weeks was PPHN. So you can see now that the baseline and systole and did not go back to the baseline again and diastole. So that's double peak, and one in systole and one in diastole. So what you can notice here as well in this number, do you think if you look at these numbers, do you think that these numbers are normal? So that's normal blood pressure. 38 weeks was pulmonary hypertension and 38 mean blood pressure. So the team, they missed to interpret in this case because they relied on mean arterial pressure. So 39 was normal. But what do you think about systolic blood pressure? 47 millimeter mercury. Is it normal for 38 weeks, 3 days old? So the lowest systolic blood pressure acceptable for turn is around 59 as percentile curve, 59. So that's actually low. And low systolic pressure was maintained diastolic. 31 is still normal. Diastolic pressure for this infant was because of low cardiac output. So this infant had low cardiac output. This infant was pulmonary hypertension. That's the highest. He was on almost 50% FiO2, and there's actually the saturation, the saturation, pre-ductal saturation, I believe, in this infant. So that's actually the waveform that you can see in infant with poor myocardial performance. And look at systole. You missed this case because you looked at the mean and you missed the systole. I mean like anyone, not anyone specific. So again, you have double hump. The first one is systole, and second one is a little bit smaller, which is diastole, and back to the baseline again. I give you this actually example from the baby which is existing right now in the unit. And I moved today between babies, and I took a snapshot for this baby, and I did an echo after that. So what you see here is the double hump, and it is different from the down one. Still, you have pulse pressure high in both infants. I cannot roll PDA even in the second one because the pulse pressure is more than 30. But you have double hump. That's actually another sign of PDA. But it could be myocardial, it could be aortic regurg. So you still need to do an echo. You cannot just jump and treat based on that, but it can give you an idea about what's going on. So that's actually an infant, and I did an echo just half an hour after this snapshot, and the PD is moderate with absent diastolic flow in the celiac artery. What's the case if you have left ventricle outflow obstruction, aortic stenosis, or hypoplastic left heart syndrome? In this case, you have normal diastole, but the peak systole will be low, and the pulse, the total duration will be a little bit more than expected. We call that Pulsus Parvus, as like mentioned in the literature. You have low systolic pressure, low pulse pressure, and normal diastole. You may detect that as differential diagnosis, a significant aortic stenosis or hypoplastic left heart syndrome. It's important that presence of more than one pathophysiologic mechanism in the same patient is also common. This simple approach might not be enough for complicated cases or if you have multiple mechanisms. So this is actually the chart that we have it in the unit. It is based on this study done in California a long time ago, determination of blood pressure in infants. It's the largest prospective multicenter trial to detect the centile curves for the blood pressure. I will have some case scenarios, and I will discuss these case scenarios and interpretation based on this graph. So you have case number 1. Term baby girl born at 41 weeks, 4 kilogram, LGA, delivered by crash C-section due to absent fetal heart rate. First, arterial blood gas was very acidotic, and lactate was 22, base excess or base deficit minus 18. Started cooling protocol on mechanical ventilation. Until now, that's straightforward. Okay. Look at the blood pressure. So that's actually the blood pressure over the second and third day of life. So that's the blood pressure at the beginning, and if you have this blood pressure here, and this is actually the normal for 40 weeks gestational age. So what do you think the most common issue here? So the mean is little bit less than 40, so they started medication. So what do you think the main issue here? Is it systolic or diastolic, or both? So we have the lowest systolic is 60, and the lowest diastolic is around 30, but you have the diastolic here is 30. So which one is more affected, or more than the other, or lower? Diastolic. So what makes sense to start at this infant? What's the medication to make more sense to start? Dobutamine or dopamine? Remember, dobutamine is vasodilator, but it's vasodilator at certain dose limit. So if you are reaching close to 10 mics per kg per minute, it's more vasodilator. But in lower dose, you may have actually even vasoconstrictor effect, not the vasodilator effect. Vasodilator is more with the higher dose. So they started dobutamine in this case, and the blood pressure a little bit improved. They started dobutamine of 5, and it a little bit improved, but the blood pressure, the mean did not improve. They keep increasing until you reach 12, and now you have the blood pressure start to drop again. But the systolic blood pressure improved, but what happened for systolic? It's worsened. And what happened for the pulse pressure? Very narrow. Very, very narrow. That's actually pulse pressure of a dying baby. So you have almost systole, like few millimeter mercury systole above the diastole. So they started to increase the dobutamine, and they added dopamine of 10 and increased to 15. At the end, they added actually also epinephrine. 0.1, they reached 1 mics. That's huge. 1 mic of epinephrine equivalent to 100 mics of dopamine. Epinephrine is 100 times stronger than dopamine. So that's actually huge dose. And what's the main issue here? Is very narrow pulse pressure, and most of the time you have low systolic pressure. You have the low diastolic blood pressure maybe because of the vasodilator effect of the dobutamine, but after they started higher doses of epinephrine, now the diastolic blood pressure improved a little bit, but you have very narrow pulse pressure and low systole. So how to deal with this case if you are the attending? That's a real case scenario, but it was at St. Boniface Hospital and not at HEC. Very good.
Vasopressin.
Vasopressin. Someone said vasopressin. Okay, that's a very good suggestion.
Yes.
But like we need to understand what's the pathophysiologic mechanism. So we have low systolic pressure and narrow pulse pressure. So either poor contractility or very low preload, extremely low preload. So the low preload, as we mentioned before, could be high mean air pressure. So we have very high descending pressure. So we have to rule out that. Or could be pulmonary hypertension. We need to rule out that. So we have 3 different differential diagnoses, and we need to rule out one by one. So we need to look at the X-ray. They added, I forget to mention that they added hydrocortisone as well without improvement. And uric for the first 3 days, no 1 drop of urine for 3 days, and lactic acid start to increase again back to 14. I have to remind you that dobutamine is potentially vasoconstrictor in the lower dose range, but still positive in entropy. Once you increase the dose higher than 5 mics, you may get the higher range of dose, which is more vasodilator. But you have another thing, don't forget that. Decrease myocardial compliance. Dobutamine, it might increase the diastolic compliance, so you need to give more fluids. If you have low preload, you will actually worsen the filling by giving dobutamine. So you have to improve that by giving more fluids. Then that's X-ray. There is no any clear impression of hyperinflation. That's actually PEEP on mechanical ventilation and PEEP of 6. And there is no edema, so there is no significant third space losses. Like I cannot appreciate significant edema even from the X-ray. So there is no impression of significant third space losses. There is no significant hyperinflation. So what's left? could be the reason for low preload, could be pulmonary hypertension. So he's on room air. Being in room air, does it rule out pulmonary hypertension? No. He's a HIE baby on cooling, and he does not require high oxygen to maintain his metabolism. So he's on room air, but this is actually the heart in the echo. So you can, from the first impression, recognize that the contractility is not really good. But I'll actually, without having the pulse wave, I can see there's Pulsus Alternans, weak alternating with strong beat, weak, strong, weak, strong. Can you recognize that? But what's the most clear here? Empty left ventricle. There is nothing in the left ventricle left. Right ventricle is more filled compared to the left. And there is no venous return to the left atria. So that's actually impression of pulmonary hypertension. Hypovolemia, but pulmonary hypertension. And this is actually the interlateral septum pushed from right to left. You have mainly right to left shunt through the foramen ovale. And I don't have the septal flattening. Septum was almost very flat or pushed from right to left. So that's suprasystemic pulmonary artery pressure. So the impaired filling of the left ventricle because of the significant high pulmonary vascular resistance. So what we did in this case, we have given this infant 50 ml per kg over 2 hours of fluids. So 20 and then check by another echo, 20 and then check another echo and then give 10. In literature you can give in hypovolemic infant up to 60 ml per kg per minute up in 2 to 3 hours. But we have also started vasopressin in this case, and what we did with the other medication, dobutamine, dopamine, and epinephrine. So what do you think that we did over 2 hours on these medications? We turned it off. You don't have to wean. If you think that these medications actually making troubles, you don't have to wean. Wean the medication if you think that the medication making benefit. So we turn it off one by one. So bolus of normosaline turned the dobutamine off. Bolus of normosaline turned the dopamine off. Bolus of normosaline turned the epinephrine off. And I was able to see the blood pressure even improving. It was turning off these medications. And there's the blood pressure. Now we have wide pulse pressure, normal systole and diastole. And I will show you the echo 24 hours after the intervention. So that's the first day. You can see the date, exactly 24 hours. It's a different person. So after almost dying from compromised systemic circulation, like in 6 hours, he was off everything and just on small dose of vasopressin and given good fluid volume. So relying on the trend of the blood pressure, if you go back, relying on the trend of the blood pressure, systole, diastole, plus the pulse pressure difference, you can recognize that systolic was very low in this case because of significant low preload, and also the pulmonary hypertension is still echo, very important to do in this case. But even before that, if we keep increasing the medications, and all of these are strong inotropic support, and there is no improvement, you have to think about other differential diagnosis of the systolic blood pressure being low preload, which could be again high mean air pressure, high pulmonary vascular resistance, or high overall body fluid, which doesn't make sense in this case as HIE, because there was no any reason for this baby to lose significant amount of fluid. So pulmonary hypertension was expected, and we started nitric oxide for sure before vasopressin in this case.
Is there a question? Sorry, going on. Does heart rate give a clue to the condition? You're only talking of blood pressure here, but is heart?
Not very important. I will be talking about that in different session, about the markers of poor perfusion. That's a heart rate here. So that's a heart rate was 100. If the heart rate really significantly increased significantly, it might be a sign of decompensation. But remember, this is HIA baby on cooling. So to begin with, his heart rate, lower resting heart rate is like expected, lower than normal. So his heart rate was below 100 for most of the time. So lessons from case number 1. Low systolic pressure with narrow pulse pressure is due to either poor contractility or low preload to begin with. And then low preload could be high mean air pressure, pulmonary hypertension, third space loss, or low intravascular volume. So we have to take one by one, which one make more sense with the clinical context in this case. HIE on cooling may develop pulmonary hypertension without increase in FiO2 because he does not require such high oxygen to maintain his metabolism. So being in room air does not rule out even suprasystemic pulmonary hypertension, especially in HIE cases. Consider bolus of normal saline before start any troops, because dobutamine as a medication might actually worsen diastolic filling. So especially in dobutamine, remember, if you don't know what's the filling of the ventricle, give a bolus of normal saline. 10 to 20 is reasonable to be given in this situation. If there is no response from any troops and they keep increasing any troops, you have to think about different pathophysiologic mechanism. It could be pulmonary hypertension, could be third space loss of fluids. So don't keep increasing. If you keep increasing and there is no response within 2 to 3 hours, you have to think about different pathophysiologic mechanism. Now I have case number 2.
Can I ask a question?
You can.
So, in retrospect, okay,
Yes.
I mean, I have to say, I don't like dobutamine,
Yes.
okay? And so, would it not have made more sense, and might you have avoided 3 inotropes and whatever else, if you'd started with dopamine in this situation at 5, and then worked from
My
there?
question is, why wouldn't you start with fluid? To me,
Well, no, okay.
I would have gone
That I-
60
that I
kilo
would
on
agree
day
with.
1
That
to
I would agree with.
Yes.
And then go to dopamine, to dopamine at 5.
Okay, so I have a very interesting question from Dr. Sechia. Dr. Sechia is one of the most expert neonatologists in Canada. So, and she's asking a very smart question. So if we started this case in dopamine to begin with, I'm not really sure if dopamine, even if we increasing the dose, will be improving the pulmonary hypertension and filling of the ventricle in this case. And I would consider maybe give more fluids.
Yeah.
But to give 50 ml per kg without having impression from the echo might be very difficult. I don't think any neonatologist will be like happy to give such a huge amount of fluid in any HIE baby with restricted fluid. But if you the message from this case, please look at the systolic and the diastolic blood pressure to get more input. And if you have collapsing circulation with low systolic pressure and you cannot sort it out, ask for early echo. If there is no improvement, to rule out pulmonary hypertension and to assess the filling of the ventricle, which make more sense. Now I have another case, which is also interesting case. Preterm, born at 26 weeks, post-menstrual age at the time of assessment 29 weeks, developed oliguria, did not respond to 2 boluses of normal saline. No acidosis, on CPAP of 6 and FiO2 23%. So this is a blood pressure trend. And you can notice here that the blood pressure dropped at this point. So you have systolic blood pressure 37, and I ignored actually the mean. 37 and 19, which one is more lower compared to the gestational age here? So the lowest acceptable systole is 42, so it is low. But the diastole should be more than 20. Now we have 19, still low. So you have low systole and the low diastole. So would you consider this case with poor contractility or low systemic vascular resistance? Poor contractility. Okay. So the answer is no. It has low systemic vascular resistance because the pulse pressure is maintained. So this infant was started on dopamine of 5 mix and then improved with 1 bolus of normal saline. The blood pressure improved immediately after, but did not improve for the rest of the time. And then at some point, the blood pressure improved significantly because we changed the medication from dopamine to vasopressin. And I will show you the trend in this case. So here, this is when at 8 o'clock in the morning the blood pressure started to drop. And you can see the pulse pressure is maintained even when the blood pressure dropped. So the systole dropped because the heart does not require to pump against with a high afterload against low resistance. So the main issue here is low resistance, and the heart is now contracting against low resistance, so he doesn't need that high pressure. So the reflection of that will be on the pulse pressure, blood pressure all through maintained. So the main issue here is low resistance, not the poor contractility, and I will show you the echo. So we started dopamine at this point, but the blood pressure did not improve. See the difference here? Within 1 hour of start of vasopressin, the blood pressure improved. Just to remind you, dopamine of less than 5, it's more vasodilator to the renal, intestinal, coronary arteries, very mild in entropy, and maybe mild overall vascular restriction, but that's in term, not in preterm. Preterm they may actually, even if you start 2 mics or lower dose, they may get the same effect. To get the vasoconstrictor effect of dopamine, you need higher dose, like more than 8 mics. And we don't know exactly the exact effective dose in preterm infants. That's actually more based on research in term infants. But this infant did not respond to low dose of dopamine. So if you start dopamine as vasoconstrictor, you have to start at a higher dose, at 10 or higher than 8. If you need to get the vasoconstrictor effect of dopamine, or start with norepinephrine to begin with, even with low dose. So that's the heart. Do you expect more contractility? That's more hyperdynamic heart. Lessons from case number 2. The mechanism in this case was low systemic vascular resistance. Low systolic blood pressure with normal pulse pressure was due to low afterload. So low systole in this case was due to low resistance. So the heart pumping the blood against low resistance. He doesn't need that much high afterload. But to pick up this case, look at the pulse pressure. Pulse pressure was maintained. But for low systole, poor contractility, the blood pressure should be narrow. If there is no adequate response from dual acting drug, dopamine or epinephrine, because they are inotropic and vasopressor at the same time, shift to pure vasopressor, which is norepinephrine or vasopressin. Another case scenario, quick case scenario. So you have this infant 25 weeks, 2 days old, with hypotension and lactic acidosis of 5. And this is actually the blood pressure trend. So the blood pressure trend here, so what do you think here, the pulse pressure? Is very narrow. So that's a normal blood pressure and start to narrow it. What do you think about diastolic? Diastolic, that's actually 0.25. So the diastolic was maintained almost 25 in 25 weeks, kept all of that, this time 3 hours. Nobody noticed anything because they relied on mean arterial pressure. And lactate was started to rise from 2, 3, 5. Blood pressure was normal. Everything was like, for the team perspective at the time, was okay. So they did not consider anything at that time. But you can recognize here very narrow pulse pressure with normal diastole. So almost 25, close to 25 diastole, or around 23. That's still normal diastolic blood pressure. Sorry, that's 15. The lowest, because that's baby is just 2 days old, 25 weeks. So diastolic blood pressure down to 15 is still okay. Remember, the lowest here, that's not normal. That's the lowest, and you may need your baby to be a little bit higher to maintain his circulation. That's the lowest, 95 confidence interval. So you may have 5% of the population require much higher than that. So what we did in this case, what you would suggest to start in this case, dopamine or dobutamine? So we started dobutamine of 5 mics in this case, and the blood pressure improved. And the dobutamine we have given bolus of normal saline, I cannot remember 10 or 20 before that. And the lactate improved within hours from that. So the infant's tachycardic little bit, but the contractility is not that strong. And the cardiac output was just 65 ml per kg in this case. This table actually summarizes everything. If you have systolic low blood pressure with narrow pulse pressure, you may have one of these conditions that you may consider hypoxemic ischemic insult, or high afterload, or low preload. And any one of these cases, you need to select one of these parameters, either pulmonary vasodilator or pulmonary hypertension, or to decrease the mean air pressure if you are giving a lot of mean air pressure, or to initiate by volume expanders followed by dobutamine. Remember that look at the diastole should be normal in this case, because the dobutamine might lower the diastolic blood pressure more. So you have systole but with narrow pulse pressure. If you have diastolic low diastolic pressure with normal pulse pressure, and the best example for that is septic shock, typical septic shock, warm shock, then you have to consider more vasopressor or higher dose of dopamine, like 10 mics. That's a vasoconstrictor dose of dopamine, higher than 10. And again, start with pulse saline if you are not sure about the filling of the heart. If there is no response from dopamine, shift to norepinephrine or vasopressin. If you have both systole and diastole very low, then you have collapsing circulation. This infant, don't waste your time starting with low dose of dopamine. You can start with epinephrine, the strong medication, and you can start with a little bit higher dose, which is at least 0.1. If there is no good improvement, remember to get a random cortisol level. If you have low random cortisol level, you may consider trying loading dose of cortisol in this case, of hydrocortisone, sorry. So I am almost at the end, and I will give you 5 minutes for questions. So conclusion, you have 7 assessment steps of blood pressure, that just to summarize everything. Look at the trend of the systolic and the diastolic plus pulse pressure. That's very important. It will give you more clues, much more than what you get from mean arterial pressure. Compare the values to the normalized centile curves for the post-menstrual age. For the invasive blood pressure, assess the pattern of the waveform. It might give you a clue also about the diagnosis. Integrate the impression from systolic and diastolic pressures with other parameters like urine output, acidosis, mean air pressure, fluid status, hemoglobin, which is very important. You have to maintain adequate oxygen delivery. You have to be sure that the hemoglobin is acceptable in your case. Oxygen requirement, preferred perfusions, and the clinical condition. So you have infant with septic shock. It makes more sense to consider low peripheral vascular resistance. Change your formulated recommendation if there is if there is no improvement after 1 to 2 hours. Don't watch for a long time. If there is no improvement from like your intervention within 2 hours, think about different intervention. Or if it is worsening in less time, consider echocardiography by an expert person if the case is worsening despite multiple strategies. If you keep trying and there is no improvement, at some point you may need to get echocardiography. But before getting echocardiography, we have to know how to deal in a physiologic way with the blood pressure numbers. After improving of all of the parameters, then you can rely on mean arterial pressure. This is the value of mean arterial pressure. After normalizing all of the parameters, systole and the diastole, and you start to wean, to make your weaning much easier, then you can rely on mean arterial pressure. But to decide for the medication and to decide for your strategy, you have to look at the systolic pressure, diastolic pressure, and the pulse pressure. I am done. I'm now ready for your questions, so I will unmute everyone. Any question from Winnipeg? First? Does it make sense? Clear? Any question from outside? Any question from St. Boniface Hospital?
Thanks.
Okay, thank you.
Can I just make a comment?
Yes, yeah, sure, go
At
ahead.
the conference this past weekend, and one of the recommendations that they came up with was to change our parameters for mean blood pressure in premature infants to gestation -2, which now sounds really simplistic.